According to the 2018 statistics, 1.4 million Ugandans ages 15 to 49 are living with HIV.
We also know that there's 53,000 new infections. In other words, 53,000 people got HIV in 2019 and 21,000 people died. So we do have new data, and it's helping us understand more and more about the epidemic in Uganda.
There's an incredible history in terms of both the way Uganda identified HIV and the way your president reacted to it. And that element of support, it was a natural way of engaging at a critical time, and we sometimes forget where HIV was, 30 years ago, to where it is today, and it's phenomenal, the change and transformation.
Over the last 30 years, I think Uganda has made great strides in defeating the HIV response. We've reduced HIV prevalence from 18% in the 90s, early 90s and late 2000 to down to 6% as we speak now.
HIV has been turned medically into a chronic disease through advances in antiretroviral therapy.
As soon as you're found positive with HIV, you start treatment. That's different from the way it was before around 2015, 2011, something like that, where the guidance was that you wait until you're really unwell, you try and eat well, and then if you really get sick, that's when they put you on treatment. But over time, evidence started to show that the earlier you can hit the virus, as soon as you find it, just slam it.
The full economic cost of keeping people on treatment and implementing prevention measures is an enormous cost for Uganda.
We are really lucky that we have incredible partners who've been helping us so far. I believe something like 140 million US is being spent on ARVs alone. And we have key partners like the USA and Ireland making that a reality. As much as we appreciate that contribution, and thanks to that people have free access, what is the impact on sustainable development? That is 140 million US dollars that could have gone into schools, into roads, into improving the healthcare centers, into making sure the health workers have a better salary.
Uganda is among 51 countries that rely on international sources to fund over 75% of their HIV response.
Our PEPFAR funding for Uganda in the current year is 410 million US dollars. We've seen slight increases year on year since PEPFAR started working in Uganda in 2004.
We provide support to over 600,000 people with services with HIV and sexual reproductive information and health services.
In order to meet the growing need of increased patient numbers and further antiretroviral therapy coverage, the projected costs of comprehensive HIV care and treatment services will increase substantially.
HIV is not just some particular group's problem, it's everyone's problem. And if we acknowledge that, then we have to have a discussion about what is being done at the household level, what is being done in the communities, what is the role of the LC5s and LC1s in this? Is it reflected in the district planning or not? Then you bring it up and say what is being done in each region. If you look right now at Uganda, the highest prevalence are almost in the center, from the north all the way down to the south. So why is that? How can we improve upon it? And then you come up to the national level and you look to say, do all the line ministries realize they have to contribute to solving this? This is not a Ministry of Health problem.
We've gone a little further to engage the community and to address urgent issues that pertain to the communities and how we should fight HIV/AIDS. And that message has been taken up by local government, and the local government has used it as a work plan to get away and involve in activities that should be used to ending HIV/AIDS. So the rollout has really been of good use to to our fight, to the cause for the fight to ending HIV/AIDS in the country.
Uganda is projected to reach epidemic control of HIV by the year 2025.
Well, it's obviously a very technical epidemiological concept, but ultimately what it's about is ensuring that the number of new infections of HIV falls below the rate of deaths for any reason in the population.
That means you've now got that under control. The reason we put deaths in that way is because deaths are manageable by treatment. We have a treatment, so you can manage the number, and that's why the number of deaths have really gone down. But the number of new infections is very hard to bring down because of people's behaviors.
Epidemic control is a separate issue from ending the epidemic, which is something that we are projecting out by 2030.
Understanding the cost implication of HIV treatment vis-a-vis sustainable financing for HIV response is crucial.
We need to plan as a country to make sure that we start budgeting for that, because with time actually we are going to see more people fail and go to second line and then third line. The cohort that is on treatment now, especially that started a few years ago and even now, in the next 10 years they will be definitely on third line. So that is something that we have to factor in our budgeting process. And as a country, we must commit to take care of our own.
How feasible is it for Uganda to fund her own HIV/AIDS response in the event that external donors withdraw, especially after Uganda achieves epidemic control?
If our current investment plan is implemented and we are able to harness our resources, we will be able to raise more funds.
The $1 initiative was introduced specifically to see to it that even when donors pull out, Uganda can still continue sustainably funding her HIV response.
The $1 initiative for HIV is an initiative which has been started by the private sector. It is intended to collect money from the people of Uganda, both at home and those in the diaspora, which money is to be kept in a trust by the private sector. And the idea is that we would like that money to be collected, invested safely in treasury bills and treasury bonds and fixed deposits, and increase the capital to a level, let's say, of about $1 billion equivalent. And then the returns from the investment, which can go up to $100 million a year, then use that money to supplement the efforts by government and the efforts by development partners to finance the national HIV/AIDS response.
Once we operationalize the AIDS Trust Fund and we make sure that government puts resources there, it can act as a buffer in the meantime, but also even later when we are weaned off. We believe we can manage.
The concept of community health insurance that was, I think, has even been discussed in Parliament is a very, very important concept for HIV, because it means that people can continue to get treatment, but they share the risk among themselves. That's what insurance does, so that someone who has HIV and someone who doesn't, then that risk is shared. I think insurance is the best, the community insurance is the best solution.
While HIV has moved from a guaranteed death sentence to a chronic condition that can be kept at bay, a permanent cure has thus far eluded researchers.
We are going to have to double down on focusing on maintaining the people on treatment who are diagnosed as positive, who are on treatment, keeping all of them on treatment, and really focus in on prevention of new infections.
So if we maintain our message and we continue searching actively for those that that are sick, and we link them to care, and we improved on her adherence, because also it is one thing to give medicine, it is also one thing to maintain and ensure that everybody who is on treatment has attained undetectable viral load. Once we attain undetectable viral load and maintain, then you reduce the chance of infectivity.
Many different groups are collaborating on these and other approaches to HIV vaccine development. Non-profit organizations, governments, pharmaceutical companies, philanthropic groups, and advocacy organizations are all working together in what has become a truly global effort toward an HIV vaccine to see the end of HIV by the year 2030.
And this effort has been spearheaded by none other than His Excellency the President of the Republic of Uganda, and that is why Uganda AIDS Commission resides in Office of the President to ensure that we spearhead the fight against HIV/AIDS.
It requires all of us to work together to reach that goal. And that means there is a degree of individual responsibility for people to educate themselves and their family members and their communities, to protect themselves, to understand what they need to do to prevent and stop the transmission of HIV, because we can't be everywhere, governments can't be everywhere, nor should they be.
If Uganda was capable of mobilizing 192 member states to get them to agree to a common agenda, surely we can find a way to make sure that those principles of leaving no one behind, of putting people, planet, and peace at the epicenter of our work can be brought to bear in Uganda today.
My message is very clear. We need to continue dealing with the stigma that keeps away the people from accessing the care. But also let everyone know their HIV status. Let all those people who know their HIV, that they are HIV positive, get on treatment, adhere to treatment, and work hard to make sure that they attain undetectable viral load and maintain that undetectable viral load.
The people who are living with HIV will be with us for many generations, for many years to come, up until they reach their old age and they pass on. What we need to do is to stop new ones. If we do that, then we'll be able to actually reach a point where we don't have HIV, and ultimately we won't have AIDS, because the virus over time, when people are on treatment, the virus will die out. But that is something that will take time. We are aiming for 2030 to reach the point of where we are reducing AIDS as a public health problem. Uganda is on track to be able to accomplish that by 2030.